Okay. Well, here we are, a bit late. Trying some new things this time around. One of them, I got some new software upgraded, and we're going to try. And also streaming this to YouTube right now. If you're familiar at all with the YouTube channel, you can get some people on there too. So we're trying to branch out for some new things, and I should probably start over. Welcome to BreatheTV. My name is Mike Hess. For those of you who are new to the program today and are wondering just what the heck I'm rambling on about, this is our periodic look into the world of COPD, where we have our Facebook page, COPD Navigator, our Facebook group, COPD Navigator, and our YouTube channel. All together, we come together about once every 2 weeks or so and see what's new in the world of COPD, what is a hot topic in the world of COPD. Today we're going to be talking about end-of-life care. Difficult conversations, but of course very necessary. And after that, we have some time to take everybody's questions and answers. So let's go ahead and be sure to get those in while I'm continuing to ramble around at the beginning of the show here. Also, make sure you go ahead and get your questions in. Questions, comments, all that stuff. I'm looking to have some celebrations today. It's one of those things that we'll talk a little bit as the show goes on here, but we know that mental stress is a huge part of COPD, and taking care of that stress is a huge part of COPD care. So if you've got anything to celebrate today, let's get those into the comments. And hopefully, if all this new setup and commenting stuff is actually working, which does remain to be seen, we will get to that as we go on. So without further ado, let's take a look at our first news item of the day. And this is probably kind of a no-brainer for a lot of people out there. But a new study out just this month, in the last couple of weeks, looks like it was published on my birthday, as a matter of fact. That's kind of cool. Studied in the Journal of the American Medical Association, one of the more prestigious journals out there, found that air pollution can increase the risk of emphysema among people who have never smoked. Of course, about 1 in 4 to 1 in 5, I guess that'd be the other way around, about 20 to 25% of cases of COPD are in people who have never smoked. Whether it's from secondhand smoke, whether it's from some of the genetic forms of COPD like alpha-1 antitrypsin deficiency, or now we're seeing that it is also in here with people with who live in air pollution areas. So what they did, this study group, they looked at about 7,000 participants, about half and half split between males and females, 47% male, average age of 60 years old, and they followed them for about 10 years. They looked for people who lived in one of 6 cities: New York City, Baltimore, Maryland, Chicago, Illinois, Los Angeles, California, Winston-Salem, North Carolina, and St. Paul, Minnesota. And they looked at the 4 main kinds of air pollution, which they designated ground level ozone. As we know, ozone higher up in the atmosphere is actually somewhat beneficial for us, but that ozone that hangs out at ground level can be a bit of an irritant. Fine particulate matter, nitrogen oxide, and black carbon air pollution. And they found they estimated levels based on these home cities. And then they followed them for about 10 years, and they had regular CT scans to see what the actual visible progression of emphysema was. This was not necessarily something to do with lung function testing or anything like that, but this was actually a measure of the damage itself. And they found whether pollution levels in these cities were tied to progression of emphysema, and sure enough, they found that higher levels of all 4 pollutants at baseline were indeed associated with small but statistically significant increases in the risk of emphysema. And in addition, they found that those folks who were exposed to more ozone, that ground level ozone, had a faster rate of decline in their lung function, particularly that when you go in for that spirometry test where you have that big breath in and keep blowing and keep blowing and keep blowing, that bit that comes out in the first second, called the forced expiratory volume in 1 second, or FEV1, did tend to decline faster in folks who were exposed to that ozone, likely because of the inflammatory irritant capacity of that. Excuse me. And they also found that those folks who are exposed to higher levels of all four together tended to have lower lung function than anybody who might be exposed to just one or two. So they all kind of work together with that. This was a study done by, in cooperation with the National Heart, Lung, and Blood Institute. So they brought in Dr. James Kiley, the director of the Lung Diseases Division at NHLBI, who gave the quote of, "These findings may offer one explanation for why emphysema is found in some people who never smoked. Of course, there are several other explanations like we were talking about, but this does put us on the path to having some other explanations for that." All right, now I will be looking off to the side here for just a little bit because I am trying to figure out whether or not these chats are actually working or not. I'm supposed to have some kind of unified chat, and I see since Andy and David have both said good morning, checking in here, just got a weird error message that I skipped ahead, although I did not. But so the unified chat's not working. That's still going to be a bit of a work in progress, but I do want to say hello to Andy checking in from the UK, and David checking in from New Mexico, I believe, down in the Southwest at any rate. I appreciate everybody taking some of their time out of their Wednesday today to join us. Next up on the old news agenda is actually some good news for lungs. We talked about pollution being bad. Now we find something that is non-medicinal and not even a procedure that might even be extra beneficial. We, of course, all know that any kind of activity is going to be somewhat beneficial, but of course the trade-off is a lot of times with COPD, it can be difficult to do that exercise. You know, we talk about pulmonary rehab and things like that, and people, you know, I tell people that, well, they're going to help you exercise. They look at me like I've grown a third head or something like that, or even a second head. But we found that even low impact exercises like yoga can potentially have some beneficial effects. This was a result of a new meta-analysis or study of studies where they looked at 11 randomized controlled trials covering 586 patients. Now that's not a whole lot of trials and that's not a whole lot of patients, but this is a very preliminary study, and the authors absolutely highlight that and recognize that, but everything starts somewhere. And they found, they looked at all of these studies that looked at either doing yoga or not doing yoga, or somehow doing what they call sham yoga, which is some kind of pretend yoga. I have no idea how that works. I didn't have time to go in and read exactly how that works, but I am kind of fascinated about how one might do fake yoga. But and then they also looked at them as the traditional kind of yoga with motion, you know, all the downward dog and the stretching and all that stuff, or whether it was just yoga type breathing, you know, that controlled kind of breathing pattern, mindfulness, and that sort of thing. And they did find that yoga was more effective than no treatment for improving quality of life. And actually kind of impressively so. They found that the mean difference with all these pooled studies was, if I'm reading this correctly, about 3.81, and we know that a difference in 2 is what is considered clinically significant. So this was a pretty good intervention with that for quality of life purposes. And in addition, they found that people were actually able to walk a little bit farther, about 25 extra meters in the 6-minute walk test. And they did see about a 4% improvement in their FEV1s, that forced expiratory volume in 1 second. So that is all very good news. And they also found that whether this is good news or simply interesting news, the breathing-focused yoga interventions were the ones that really got people the improvements. The complex motions and things like that didn't really seem to have much of an impact. Which could be related to extra muscle work leading to extra oxygen demand. Could be that people were just not able to do those very effectively, and so a loss of focus on the breath work was actually detrimental. Not entirely sure. While we talked about one of the downsides of this study being that it was relatively small sample size, they also wanted to point out that there wasn't a lot of reporting on adverse effects. You know, anytime we do a study on any kind of potentially new intervention, we want to make sure that it's safe for people to do, but most of these studies did not really report much in the way of safety. Now, in good news, those studies that did report on safety did tend to say that adverse effects were very minimal and relatively uncommon, which one might expect from yoga. It's generally considered a low-impact workout, especially if we're just focusing on breathing work. But it is something to consider, as with any exercise plan. So, yoga good, air pollution bad. Third up on the agenda today, again, this is probably kind of a no-brainer, but it highlights the importance of trying to bring attention to some of this stuff in the setting of COPD. This study came out of the University of Alabama in Birmingham, at Birmingham, as part of the ongoing massive COPD gene study, which has been looking at over 10,000 people. And looking at long-term outcomes, looking at subsets, trying to figure out whether we need to be looking at different types of COPD in different ways and that sort of thing. So in this group, they identified 5,000 current and former smokers, 45% of whom had COPD, the other half did not. So this is looking at a wide variety of people: smokers, non-smokers, people with COPD, people without COPD, all of whom experienced at some point anxiety and or depression symptoms. About 19.7% had anxiety symptoms, and about 20% of those, about 19% of the overall cohort, the overall group, had anxiety issues, concerns, balanced well between those who had COPD and those who did not. They also found that folks who had what would normally be considered, or what is often considered, severe to very severe COPD is based on the spirometry staging system we talked about the last time we were all together, that significant airflow obstruction. They found that about 20% of those folks had depression or depression symptoms, compared with about 13% of the entire cohort. So, as one might expect, the worse your symptoms get, the more depressed you might get. Now, why is that important? Well, this is also highlighting the idea that we know that if you have increased depression symptoms, you are less likely to adhere to your therapy regimen, whether it's taking your inhalers or going to pulmonary rehab or doing yoga or what have you. We find that it's associated with increased risk of hospitalization, increased earlier mortality, all of the bad things. So we really want to focus on getting these symptoms addressed, finding out what we can do to help, and making sure people are getting connected with the tools and services that they need to address these symptoms. Of note, they also found that those folks, 66% did seem to be unmedicated at all. And of course, medication is not always the only or even the first answer to any of these symptoms, but it is an important part of mental health. They found that you are more likely to have these unmedicated symptoms if you were of African American descent, if you were male, if you didn't have health insurance, if you again had the severe to very severe COPD, or if you had even higher levels of symptoms with regardless of that airflow obstruction. So it's important that if you, the biggest takeaway here is that it is important, if you're having these symptoms, if you're experiencing these symptoms, please don't hesitate. Don't try to push them off. Don't try to just say, I'll get better, I'll do this. Please get them addressed, whether it's with your primary care provider, whether it's with a mental health professional, a counselor, even calling one of the various helplines that are out there. Please go ahead and get that taken care of and get the care that you need and deserve. Also want to throw a quick highlight out there. Recruiting, still a study still recruiting for those folks with COPD who are considered overweight or obese. We're looking at how COPD affects the impacts of these disease processes, how they all work together to influence each other and to get all that stuff fixed. So this is the Insight COPD study, and I encourage everybody to check that out as much as possible. So good. Let's see, Valerie, I think you're coming ahead from the UK also, so that would be a good afternoon, a good evening for you. Thank you for stopping by. Going back in, one other news item here. We have one last golf outing remaining from our surge of golf outings. We're really trying to get some more registrations here to get us over the finish line. Here in Kalamazoo on September 7th, we're going to have the short breath, short course scramble at Red Arrow Golf Course. You can hit us up there are links in on our Facebook page, COPD Navigator. There are some links on the Breathe Kalamazoo website, breathekzoo.com. We can get links. Drop a line in the comments somewhere. I will eventually see it, and I will send you a link. Like I said, we've got a little over a week to go. We still want to get some more registrations here to try and get us over the edge and raise some money and awareness and have a good time, all in the name of COPD. So please, if you haven't, hi Linda, another page there. Linda, the Alpha 1 antitrypsin golf outing a couple weeks ago, I believe was very successful, and I appreciate you stopping by, Linda, and hopefully we can get some words of wisdom to drum up some more support for our event down here in Kalamazoo. Also coming up new, if you happen to find yourself going to copdnavigator.net, that is a website that we've had the domain for a while. It's kind of been, what's the word, kind of laying unaddressed for a little while because had a lot of stuff going on this summer. Fortunately, some of that is dying down a little bit. I am very proud and pleased to announce that I have finished graduate school and now have a master's degree in public health. The upshot is I don't have to worry so much about theses and papers and practicums and all that stuff anymore, so I can readdress some time back here to get more of the digital presence going again, get people access again to the tools they need to be partners in their care and get stuff going. So if you head over there, still developing a lot of stuff. I've finally found what appears to be a decent enough framework for the website and getting some blog and commentary materials up there. We got some printable resources. We're going to have a repository of all these videos and any other media. Getting ready to kick back into some podcasting, do some more how-to videos, like we have the dry powder inhaler one, getting ready to do a meter dose inhaler one, getting ready to talk about oxygen, all in a shorter format, so that if you don't have an hour to kill to listen to me ramble on, you're able to get kind of the high notes of what you need. So check that out. Feel free to offer some suggestions and let me know what you think. So on to today's main topic, our lesson plan for the day. It is very difficult in our culture, our society, to talk about the end of life. We have, of course, nobody really wants to think about that. Nobody really wants to quote unquote look forward to that, but that has unfortunately done us a lot of disservice. We know that a great deal of medical spending is done in the last 6 months of life on average. We know that many people do not get to pass the way they want to pass on their terms or in the settings that they choose or anything like that. And we have to look at why. And again, part of that is because we have these difficult conversations. Part of that is we simply don't think to tell anyone what we want. And so then when the time comes that we are unable to speak for ourselves, for example, if you have a really bad exacerbation and you end up in the hospital and you end up on a ventilator with a tube down your throat and sedated and all that stuff, it's very difficult to convey your wishes. Even when you're able to speak or communicate, you may be under the influence of medications to help keep you comfortable. You may be scared. You may not necessarily be in your right mind. And your loved ones, friends and family, may not know exactly what you want either. So that's why it's really important to start having some of these conversations and to kind of break through that difficulty aspect of it, to make sure that you are still able to express what you want as you approach the end. And so there are a couple of different ways that we need to look at this stuff. And it's important because I should say it's particularly important in COPD because in other respiratory conditions, this is maybe not to the extent that we want or we think is appropriate, but the message is getting out. On the screen here is commentary from the European Respiratory Journal over 10 years ago now, where they found that compared with people with lung cancer, people with COPD were more likely to die in the intensive care unit, on a ventilator, and with shortness of breath. Now you say, okay, well, they found that 10 years ago. Certainly we've done a better job of that, but we haven't. There was an article, there have been a couple of articles specifically comparing lung cancer with COPD, because those are probably the two biggest pulmonary causes of mortality throughout the world. And they found that consistently people with lung cancer are more likely to access palliative care services, hospice services. They're more likely to die in the setting that they want, whether it's at home, whether it's at an inpatient hospice, whatever it is. They're more likely to be comfortable and cared for than people with COPD. And so we really have to, again, ask ourselves why that is. Why is it that these two, hesitate to use the word similar, but in some respects they are similar, these two relatively related or companion-ish kind of conditions, why do they have such widely varying outcomes? I mean, we're talking 25, 30% sometimes of a difference between the lung cancer and COPD, people going where they want to go. And I think it's because we often focus on, we get so caught up in talking about inhalers and pulmonary rehab and all of those things that we forget that we as clinicians forget that we have to be taking care of the entire patient, their entire family, all of these things. We can't just keep throwing more and more stuff at folks to try to make them feel better. It's complex stuff. It's all that. We need to make sure that we're caring for people throughout the entire scope of our practice, and that includes having these difficult conversations. Now, how do we do that? First off, we're doing it here, and I don't know if I'm doing a very good job of it because it's difficult for me to contemplate that. I'm got a kid just started college. I've got two more, one in high school, one in middle school. That's not the kind of thing that I want to have a chat with, but unfortunately, I have seen, especially in my intensive care days, far too many people who get into the situation where they've got one child is saying, yes, mom, dad, grandpa, grandma, they wanted everything done. And then another one comes in and says, no, I know them better. I've known them longer. I've talked to them sooner. They don't want any of this stuff. And then you have bad blood inside the family, and you've got clinicians who are uncomfortable and don't know what to do, and you've got the poor person who is actively in pain and all that stuff, and they're maybe not getting what they want. So what we can do with that, there are a couple of different strategies in order to do that. And so all of these things are going to vary depending on the state you live in and the country you live in many cases. We've got some international folks coming in today, so I appreciate that. Your own personal preferences, all of these things, but it's important to get these things on record and at least have the conversation so that when the time comes, and if you can't speak for yourself, your wishes will be respected. The first one we're going to talk about is arguably the one that most people think about first when they hear this whole idea of end-of-life care and advanced directives and things like that. This is what's called a living will. Basically what this is a written down set of instructions that are written by you, which is going to be important later on as we continue the conversation, regarding what you want. These include all kinds of things, whether it's you want to be resuscitated, do the CPR, the pounding on the chest, whether you want to have medications to try and restart your heart, whether you want to go on machines like a ventilator or like a kidney dialysis machine, whether you want to have your organs donated. This is basically, like I said, a set of instructions that guides the people who are actively making the decisions when you are unable to speak for yourself. This is something that you keep on file, something that you want to make sure that all the people that are around you or may be in a position to speak for you after this care, or after you're unable to speak for yourselves, you want to make sure that they're aware of it, they know how to find it, and they know how important it is to you so that they can continue on and obey your wishes. The companion sort of thing to that is what's called a durable power of attorney, where the living will or advance directive has a list of what your decisions are. The durable power of attorney for healthcare is who makes that decision. This isn't a person that you legally appoint to be your agent, your proxy. There are a couple of different words for it. Who will make the decisions in your stead. Now, as you can see on the screen, this can actually be multiple people, and that is often recommended because, of course, if you have one person and maybe they're unavailable or can't be reached or they've moved away, or maybe worst case scenario, you're in the same accident or something like that. It's good to have kind of a backup to the backup. The flip side to that is you need to make sure that when you select these people, that they're going to be on the same page. Otherwise, you really haven't made a lot of progress beyond the whole idea of just kind of putting this out there and letting the people who are there bicker it out. Because if you have two people who are designated, depending on how you write the DPOA, depending on how the lawyer sets it up and all that stuff, they could have equal power. You may have a primary and a secondary, that sort of thing. It's also important to note that this is not necessarily permanent. First of all, the durable power of attorney only takes over when you are deemed by, I believe in most cases, it's 2 clinicians, although this again is going to vary state to state, legality to legality, state, country, whatever it is. You have to be deemed not competent. You have to be evaluated by professionals and say that you are not able to make your medical decisions. Sometimes that's pretty clear. Sometimes, like I said, if you are out and collapse and the EMS comes and puts a breathing tube in and all that stuff and takes you to the hospital, you're pretty well unable to make your own decisions at that point. But sometimes when we have progressive diseases, progressive dementias and things like that, it's difficult to know when somebody is able to make those decisions or not. This is something we dealt with on my own family. One of my grandparents, toward the end of their life, could be very lucid at times and they were making decisions and taking care of themselves and all that sort of thing. But at the same time, they were making a lot of odd decisions about not wanting to go to a doctor for example. Now, it's very difficult sometimes to say, is this the wrong decision or is it simply a decision that I don't agree with? And so that's why it's important to remember that. And I shouldn't say that. I've used that phrase a lot, but I think it's easy for people to get concerned about, well, if I sign this durable power of attorney, then XYZ person, if they get mad at me, then they're just going to take my car away, or they're going to put me in a home, or they're going to do this, or they're going to do that. And that doesn't necessarily happen. I mean, this is, again, something that you have to be declared not competent to make your own decisions, not act in your own best interest, and then people can help you make better decisions or more comfortable decisions is probably a better way to put it. In addition, if you have a situation where you are not competent, somebody makes the decisions for you, and then you recover, you can revoke that. You can revoke the power of attorney and go back to being your own agent. It's not a permanent thing. This is not signing your life away or anything like that. This is simply finding somebody who can act in your stead when you're not able to, and who is on board with what you want, knows what you want, and is willing to go forward with that. The other thing to bear in mind is this person has to accept that responsibility. When my wife and I were appointed power of attorney for this grandparent, not only did the person, the patient in this case, have to declare that, we had to accept that too. We had to swear that we accepted that. So this isn't anything that you just can drop on somebody or pick somebody at random. Everybody's got to be on the same page in order to make this work. Just going to hop back here a little bit. So Andy from the UK, a lot of talk in the UK about assisted dying. Or leaving a living will stating your wishes. And this is a very, very, very controversial issue no matter where you go. The idea, a lot of times, if you've been, most people will probably remember Dr. Kevorkian, who wanted to help people end their, if they have these terminal situations, terminal pain, terminal discomfort. There are now a couple of countries, and I believe even a few states here, where you can get kind of that assisted passing, assisted dying, as it might be called. It's really controversial because there are a lot of variables in it. There are religious concerns, there are cultural concerns, there are personal concerns. This is another one of those situations where there's not really a right or wrong answer. What I believe is right for me, or is not going to be right for Andy, is not going to necessarily be right for my kid. It's not necessarily going to be right for my grandparent. All of these things, but this is why it's so important to have these conversations. We've got to make sure that we all have to make sure that the people who are going to be speaking for us understand why we're having this decision or this discussion. We also have to make sure that if somebody says to us, I cannot act in that capacity, I cannot do that for you, I cannot be that person, that's okay too. And that's a time where you can say, I respect that, I will find somebody else to go along with that. This again isn't on either side somebody saying that one is right and one is wrong. It's simply saying that I don't agree, I respect that, I respect your ability to make that decision, I don't agree with it, and I can't in good conscience help you execute that, implement that. So whether we're talking about assisted dying, or whether we're talking about simply what we're going to do in the hospital, in the ICU, it is very difficult to have a right or wrong answer. I would say that there are no right or wrong answers, but it's critical to have these conversations and then to implement them appropriately. So we also have this kind of new concept out there called a physician order for life-sustaining treatment. And all of these things sound like they kind of go together, but again, depending on your locality, depending on your local government requirements and so on, they all have slightly different connotations and slightly different interpretations. So the biggest difference with this POLST, as it's often called, POLST, hey, I got it right in the first try. This is actually a binding medical order. One of the things that surprises a lot of people, and surprised me when I first discovered it, was if you have an advance directive and you're out and let's say it's the stereotypical I've fallen and I can't get up kind of situation, and maybe you lose consciousness, and the EMTs, paramedics, they come and find you in your home and you can't talk. Let's say you have an advance directive that says, I don't want to be intubated, I don't want to be resuscitated, if I go, just let me go. Even if that is stapled to your chest, your shirt, the EMTs are not bound to follow that, and in many interpretations are actually bound to do the exact opposite, because that is not an order, that is your wishes. And they may interpret that as, well, we should maybe be careful with this, and so on and so forth. But again, depending on the case, that might not be respected, that might not be implemented. A physician order for life-sustaining treatment has to be. This is a legally, ethically, medically binding document signed by a provider. In most cases, most states, it still has to be a physician, although in other states, a non-physician provider, such as a nurse practitioner or physician assistant, is also able to sign these. And again, what these say, this is what happens. When you read this, you are ordered to not provide resuscitation. You are ordered to provide resuscitation. You are ordered to provide medication, but not breathing support. This is the list of stuff that you are willing to have done to you to sustain your life, hence life-sustaining treatment. There is an initiative, that's what this website on here, this polst.org. There's an initiative that is pushing for standardized systems throughout every state. it's still working on it. According to their website, there are only 3 states that have a fully implemented, or as they call it, mature POLST system. 2 of them are part of this whole collaborative, cooperative thing. One of them, Oregon, decided to take a step back just because of some philosophical differences. The practical purposes are the same. They're all working the same way. There were, as I recall, looking at the map, probably about a dozen other states who are implementing this POLST system. For better or for worse, here in Michigan, we don't have anything really. You can still fill out the form, but it's not necessarily legally binding. I would like to think that if a medical professional, whether it's in the emergency room or an EMT or what have you, saw that, then they would really strongly take a look at and strongly consider following that. But again, I'm not sure about the legalities of following that without the infrastructure, the legislative infrastructure in place. But I would strongly encourage everybody to work with, in everybody's massive amounts of spare time, work to support these initiatives throughout all the states so that they can, so that we can make sure that we're getting everybody the care that they want and the treatment that they deserve, even when they're not able to speak for themselves. This, unfortunately, also kind of goes on, for lack of a better term, from beyond, because another thing that we ran into with my grandparent was that they did not leave a will. And had they left a will, had they even a very basic one that just said, I leave everything to grandchildren, would have saved us quite a bit of hassle. Unfortunately, without that, it has to go through the entire legal judicial probate system. This is where you have to file notices with the court, and any potential creditors come out, and there are notifications published in newspapers, and it's a far more convoluted process than just having specific instructions. Now, of course, sometimes a will doesn't always make that easier. We all hear horror stories of celebrity wills and children fighting and all this sort of thing, and sometimes that happens with normal people too. But having a last will and testament is relatively easy to do, and it takes a lot of work off the shoulders of your survivors. So of course, this and this is one, honestly, that is not necessarily, there aren't as many ethical conundrums with this as there are with potentially advanced directive or the post orders. So this is one that I highly recommend everybody go out and do at your convenience. There is usually some expense to it, whether it's through a lawyer, whether it's through one of the like quickie legal things that are out there. There are websites that do these legally binding documents, and then you just need to get it notarized. Whatever it is, it's worthwhile to go ahead and do that, just to again give your survivors a little bit of peace of mind and all that stuff. So before and after the end of life, these are important conversations to have, and make sure that your wishes are known, and that makes them more likely to be met. Of course, there really is a lot more to end-of-life care, and even disease maintenance care. A lot of times there's this big confusion between what we call palliative care and hospice care and end-of-life care. And a lot of times these terms get conflated because a lot of them only come up with end-of-life stuff. Like I was saying, we often